Hello, good evening, friends. So, today we meet again in our YouTube live session in which we are going to discuss some very important topics which we consider will be the most important in your conservative dentistry, endodontics, and dental materials in your upcoming November INI examination. Now, friends, for this, we've tried to analyze the previous year's INI paper, including the most recent one that has happened in May. And obviously, before INI, we've had the AIMS examination, AIMS conducting the examination for its MDS entrances. As you all will be aware, the responsibility of setting up the paper of INI MDS is given to AIMS only, right? So we have to be very particular about reviewing and trying to analyze what the examiners sitting in AIMS expect of us, right? So when I kind of analyzed the you can say requirements or how they formulate the paper, friends, what happens is that in the recent times, more emphasis is there on clinical questions. All right, more emphasis is there on clinical questions. At the same time, from dental materials, there are certain things like questions from dental waxes, which are hardcore ratification, memory based. I mean, we can't help you with that except for the fact to tell you that these are, the thrust areas, the important areas wherein you have to, develop some kind of shortcuts, mnemonics. We are there to help you. At DBMCI, we are continuously giving you memory helpers, memory aids, simple mnemonics to kind of memorize the important, most highlighted, topics which are time and again being asked in such important examinations. So that is the basic aim of this, the basic premise of this short, you can say 45 minute YouTube live session. To make it more, you can say productive and to increase the you can say strike rate of what is going to come. The question that we are discussing will be, first of all, some of the previously asked questions, but at the same time, and more importantly, whatever possible questions that can be formulated from those existing concepts. Because usually the examiner is kind of, oscillating between what he's already asked and slightly would go to the next level. And I'll tell this by giving an example. If you see past 3-4 years papers, it's like the questions are kind of coming from similar topics. The language will be slightly changed. The content obviously will be changed just to change the question, the concepts, and the area that you have to really cover from your standard textbook would have some kind of pattern. So the idea is to understand that pattern, do those important questions, and really analyze how to crack this examination. So as far as overview of the important topics in DM is concerned, time and again, they've asked questions from dental waxes, right? Then we have the physical, mechanical, and chemical properties of dental materials. In the last YouTube session also, I discussed about the plastic deformation, brittleness. They would give you a stress strain curve and they would ask you, which material is more brittle, which material is relatively less brittle, which has got more, modulus of elasticity, which has got less modulus of elasticity, which is more flexible, which is less flexible, and so on and so forth. I discussed this kind of a very comprehensive big question I discussed in the last YouTube live session also. And it is very much expected in November INI also. Then we have dental polymers, questions coming from, say, the physical properties of polymethyl methacrylate. And that was a slightly, again, totally memory-based question, came, you can say, for the first time or the second time in this year's May examination. Then you have bonding agents and composites, always a very important topic. Please cover your Phillips. Endodontics, traumatology. Traumatology is very important. Traumatology is like the favorite topic of the AIMS endodontics department. So expect at least 2 or 3 questions from traumatology. We'll be discussing them. Isolation and rubber dam. very important. Nickel titanium files every year, whether it's a senior resident paper or the MDS entrance examination, NITI files. Vitality testing and pulpal diagnosis of the health of the pulp, very important. Conservative dentistry somehow aims cardiology is very close to the examiners of INI. They usually don't ask you very solid standard questions from Sturdivant, right from like principles of cavity prep, various differences in cavity prep from ceramic to direct filling gold to composite to amalgam to indirect composites and so on. Obviously, you have to do it. You're sitting for an examination, whether it's INI or NEET, you have to do it. But somehow, AIMS and INI, they lay less stress on these conventional things. So the strategy for today's session would be, again, similar. We'll discuss a few previous questions and we'll try to figure out what all potential new questions can be formulated from these questions. All right. So let's take up the first question, my dear friends. After a composite restoration, you see white lines along the enamel margin of a tooth. What are the possible reasons? All right. What are the possible reasons, my dear friends? Very simple. Let's just try to break this down. There is very simple. There is a class 4 kind of a situation in which there is a fracture of your upper central incisor, right? That's your central incisor. There's a fracture right across involving the incisal edge, right? And you're doing a composite buildup, right? If there is a separation, that means it implies there is some level of debonding that has taken place. Right? What are the reasons? The most and simple and the most common reason of debonding is not isolating the tooth properly and basically some problem with your steps of bonding. You've done your etching, acid etching, you've dried the tooth, saliva comes in and you do not re-etch, right? You place your bonding agent over a layer of saliva. Obviously, there is an obvious debonding that will take place. No doubt about it, right? So that's one most common reason. So out of the 4 options given, 1, 2, 3, 4, the options are, they're asking for multiple correct answers, all right? So option 4 straight away is one of the correct answers. Inadequate bonding of the composite. That obviously is the most common reason. Apart from this, what other reason can there be? Once I've done my restoration and I'm doing my finishing and polishing, if I'm doing it too aggressively and I end up damaging my cavo-surface margin, right? The margin of the restoration and the tooth, intact tooth, I would end up developing micro cracks on my tooth structure and that would end up in debonding and a white line. So traumatic restorative procedures like traumatic finishing and polishing, all right? Traumatic finishing and polishing, which would lead to, again, debonding. So one is obviously the most common reason of debonding is incorrect technique, all right? And the other is traumatic finishing and polishing leading to micro cracks in the enamel. So the other correct option is the number 1 option. It's due to micro cracks developed in the enamel surface. So our correct option is option C, in which 1 is true, first statement is true, and the 4th statement is true. Now let us look at the 2nd and the 3rd statements. What is wrong with them? Excessive pressure applied by the composite, that is the restorative material, due to use of low intensity light. See, low intensity light, use of low intensity light is actually a good thing. When you use low intensity light in the initial stages of curing, you are actually giving time for stress relaxation of the developing polymers. So the residual polymerization shrinkage stress is less. So the chances of debonding are actually less. So that's why this statement is wrong. This statement would have been correct if the examiner would have written excessive pressure by the composite due to the use of high intensity light, right? Third option, excessive etching of adjacent normal tooth structure. No harm in that. I mean, obviously, you end up damaging the normal tooth structure beyond a certain point, but it would not lead to debonding. It would actually give you a better bond. The more the surface area of adjacent, normal, healthy tooth structure you cover by etching and then bonding and then by doing a composite over it, obviously less are the chances of debonding, less are the chances of gap formation, right? So that solves this question. Now comes the important point, my dear friends. What are the other very important applied questions that can come from this? Very important. We talked about polymerization shrinkage stress. What exactly is that? I have monomers which I'm curing with my light, right? Now, when those monomers convert into a polymer, rigid polymer, there is a volumetric shrinkage of about 20% in space, in 3 dimensions. Now, my aim is bonding, right? So I have bonded that material, which is uncured, to the tooth structure. So I'm not allowing that shrinkage, that 20% shrinkage to take place. That stress is going to be borne by my bonded walls of my cavity prep. That polymerization shrinkage stress is the one that is detrimental to the long-term bond strength. And what is the value? Now, the important point is from your MCQ perspective, what is the value of polymerization shrinkage stress that we get when we light cure the composites? That's up to the tune of 15 megapascal. So that's about 15 megapascal is the polymerization shrinkage stress that a tooth's bonded surface has to endure. This brings me to the next question. What is the minimum initial bond strength of composite to the tooth structure? That is essential. So as to cover this, for this or compensate for this polymerization shrinkage stress. Common sense says it has to be more than 15 megapascal. What is that one value which you have to mark? That is 17 megapascal. So that's another MCQ. 17 megapascal is the minimum value of initial bond strength for the composite restoration to be acceptable clinically. All right. So with this one question, we've solved related other MCQs. Very important point. In one reference, see, Sturdivant gives you one value, Phillips gives you another. In one area, Sturdivant writes that polymerization shrinkage stress of about 7 megapascal is seen clinically. And Phillips says 15 megapascal. Now, for us, both are standard textbooks. We cannot ignore one and accept the other. My belief is that the examiner, if he's asking a value-based question, would not confuse you by giving both these options. So either a 15 megapascal value would be present if he's asking you polymerization shrinkage stress, or 7 megapascal value. If both are given, go with 15 megapascal. I would suggest go with 15 megapascal. All right, that's one thing. What is the next potential applied MCQ that can come from composites? Since I've taken this one MCQ of composite, I want to just do all the important value-based questions and conceptual questions. For adequate polymerization of a 2 millimeter increment or block of composite, you need at least 16,000 millijoule per centimeter square of energy intensity by your light cure gun, right? 16,000 millijoule per centimeter square. That's the minimum that is required to adequately cure, that is polymerize, a 2 millimeter block of composite. All right. Now, this can be done how? I may have my light cure gun, which is at a setting of what power wattage? Say it has a setting of 400 milliwatt per centimeter square. Then I would have to do my curing for at least 40 seconds, right? Because 400 multiplied by 40 would give me 16,000 millijoule per centimeter square. If the examiner asks you, I have a light cure gun which has a power setting of 800 milliwatt per centimeter square, then what is the time that is required that I would want to light cure a 2 mm increment of composite? Then that would be 800 multiplied by what will give me 16,000? That would be 20 seconds. So this is the applied part that the examiner can ask you. 800 multiplied by 20 is again 16,000 millijoule per centimeter square. So you see, this is the approach of correlation. You have one question from composites and you do at least 4 or 5 related questions. This brings me to the next question. This again was asked previously in your AIMS examination. Which investigation is based on AC, that is alternating current impedance spectroscopy? Now this has to be memorized, and the examiner is and the answer is Caries Scan Pro. Now this is a device. A Caries Scan Pro looks something like this. It's a handheld device, wireless, Bluetooth enabled, which basically uses a technology wherein a very small amplitude, microampere current is flown or is conducted through the dental tissues, right? Through the enamel, dentine and the pulp, right? And it assesses the level of demineralization, right? Obviously, a tooth which is not demineralized by caries will give you a higher impedance value. A tooth which is demineralized would give you a lower impedance value to alternating current. All right. So this is a ratification memory-based question. You'll have to memorize this. Another important term that is important here with the Caries Scan Pro is the term known as assist. ACIST, alternating current impedance spectroscopy technique, right? Alternating current impedance spectroscopy technique. Memorize this. Another question which is related to dental caries again came here in your AIMS examination a few years back. Which investigation is based on measurement of difference in electrical conductance? Again, something similar. There you are measuring impedance. Here you are measuring conductance. Obviously, you have a porous structure, demineralized due to caries, filled with saliva and water. That would be a good conductor of electricity. So that would give you a higher electrical conductance value as compared to intact tooth structure, which would be more insulative to the applied electric current. So there you were using, with Caries Scan Pro, you were using impedance. Here you're using electrical conductance. And there are two devices that are based on electrical conductance. One is this, which was the answer here, Vanguard electronic caries detector. That's one. So no doubt the answer here is this. The other option that can come is simply caries meter. That's another device which uses electrical conductance. So please memorize this. Caries, simply known as caries meter. All right. So this is regarding your previously asked questions, a PAQ, right? Based on impedance, that's your Caries Scan Pro. Based on electrical conductance, that your Vanguard electronic caries detector, and your caries meter. Now comes the applied part. A question that can be asked, taken that from your often repeated concept of Diagnodent. Diagnodent is another handheld pen-like device which is used to detect Number 1 MCQ, occlusal caries. Diagnodent used to detect, diagnose usually occlusal caries. Not very great at detecting proximal caries. Occlusal caries. That's one. That's MCQ number 1. The technique that it uses is laser autofluorescence or simply laser fluorescence. That's MCQ number 2 from Diagnodent. The third very important point, Diagnodent has got great sensitivity to diagnose caries. Now here I'm coming to the realm of preventive and social medicine and community dentistry. It has got great sensitivity, very high value of sensitivity, but low specificity. What do we mean by this? Sensitivity is the ability of the test to accurately diagnose disease. Here, our disease is dental caries. So sensitivity, it has got very high value of sensitivity, but very low value of specificity. That's your next 2 important MCQs. Specificity means accurately diagnose disease-free condition. Now the problem with Diagnodent is, even if you don't have caries and if there is some level of slight demineralization, not because of caries, because of some other reason, it would incorrectly diagnose it as dental caries, bringing its specificity low. And what is the next applied MCQ? If the specificity of a test is low, it implies that the number of false positives are high. Specificity is low implies increase in the diagnosis of false positives. Increase in the diagnosis of false positives is not good for us, meaning false positive. It has diagnosed the lesion as a carious lesion, but it's false. It was not a carious lesion. So incorrectly, the accuracy for diagnosis of disease-free state is low. So it's not good in that sense. Therefore, Diagnodent can never be the primary method of diagnosing dental caries. It is always an auxiliary, adjunctive method, right? So with this, we've done a few, I told you the approach and the potential MCQs. You try to get in the head of the examiner where exactly he's getting these questions from, right? And what are the potential applied MCQs that he can ask, right? Then trauma is a very favorite of our INI examiners, right? So let us just very briefly discuss trauma and some very important facts regarding trauma. I'll take slightly more amount of time in trauma here. Let us just start. Let us set the pace with a previously asked question. A 10-year-old child is brought to you 45 minutes after avulsion of the tooth. What is the next step after cleaning of the tooth? Simple. 10-year-old child means it's not really specified that it's a deciduous tooth or a permanent tooth, but in all likelihood you're dealing with, the examiner also obviously has mentioned this. I've not mentioned it here, but it was an upper central incisor, right? So you have a 10-year-old child, upper central incisor. In all likelihood, it's an open apex case. Why? Because after the eruption, which erupts by about 7.5 years of age, it takes roughly about 4 to 5 years. So for complete tooth maturation, so we're dealing with, in all likelihood, we're dealing with an open apex permanent central incisor. The catch here is, number 1, it's a 10-year-old child. The number 2 catch here is that it's a open apex permanent tooth. And the third important thing, and one of the most important thing regarding treatment planning, is the time for which the tooth remained outside the oral cavity in a dry condition. Now it has written simply 45 minutes after avulsion of the tooth. So in all likelihood, if we see the worst case scenario, it was in dry condition. The patient was not well informed enough to put it in milk or Hank's balance salt solution or Viaspan or whatever. So it was in a dry condition. Now, what is he going to do? Now that depends on our knowledge of how we manage it in the best possible manner. See friends, the best time, the ideal time to reimplant a tooth is if you reimplant it within 20 minutes of it coming out of the oral cavity. And what does that do? What is the advantage? What is the advantage? The advantage is that if the extraoral dry time is less than 20 minutes, my dear friends, there are chances that the PDL damage, the periodontal ligament damage, is localized. What is the definition? That's your applied MCQ. When we say that the PDL damage is localized, it means that roughly less than 20% of the surface area of the tooth is damaged, which means that healing will take place by regeneration of new cementum. Right? And this takes place in about 14 days following the injury. And in what all conditions does this happen? One condition is obviously this: a case of avulsion which was managed promptly. Within 20 minutes of the tooth being knocked off of the oral cavity, it was put back. That's number one situation, my dear friends. So let's see this. Let's just jot this down. Very important points. PDL damage, minimal. What is the definition? That's your MCQ. Less than 20% of the surface area of the root was involved. What is going to happen? Favorable healing. What do you mean by favorable healing? Formation of new cementum. This is MCQ. In how much time? In about 14 days. That's another MCQ. This is another MCQ. What is the definition of minimal damage? So, what are the other conditions? So, first condition is PDL damage minimal. When does it take place? In case of avulsion, in which the tooth is put back in the socket within 20 minutes of getting avulsed. Right? Next situation, any luxation injury which is not that severe, that would be a concussion injury. That would be a subluxation injury. And in some cases, when you're lucky, an extrusive luxation injury. Right? That is also relatively milder injury as compared to intrusive luxation and lateral luxation. So you're not expecting a good response of the PDL in intrusive luxation, number one, in lateral luxation, number two, and in avulsion cases where the extraoral dry time is greater than 20 minutes. Right? Never in extraoral dry time greater than 60 minutes. And you're somewhere in between when you are between 20 minutes and 60 minutes. Right? So, very important MCQs. Where all do you expect favorable response? Avulsion, in which extraoral dry time is less than 20 minutes. If it's less than 60 minutes and greater than 20 minutes, you need to be really lucky. But you can be optimistic. Concussion, subluxation, and extrusive luxation. Right? Now, in this question that came, it is 45 minutes. So we are somewhere in between and we are being optimistic. It's greater than 20 minutes, less than 60 minutes. So you can have some areas, new cementum being formed. You can have in some areas where osseous replacement resorption takes place. You want to be optimistic. You want to increase the chances that good, healing takes place. So that is regarding the PDL, right? That is what you do regarding the PDL. So that's your tooth, that's your open apex case. All right, this is what we're dealing with. So we've dealt with what we do and how we approach the case when you're dealing with the management of the PDL. What about the management of the pulp? The damaged pulp, if it's a closed apex case, never expect it to revascularize. It will never revascularize. But here we are dealing with an open apex case. And if the extraoral dry time is less than 60 minutes, which is the case here, I am going to be optimistic. That means I would try for for the fact that natural revascularization, right? Natural revascularization could take place. And for that, if the extraoral dry time is less than 60 minutes, I'm going to dip my tooth before implanting back. I'm going to dip my tooth in doxycycline solution or coat it with minocycline powder and then put it back, right? If my extraoral dry time is greater than 60 minutes, I'm not expecting revascularization, my friends. Then I'm going to take the tooth in my hand and going to do a nice root canal treatment and apexification procedure outside the oral cavity and then put the tooth back, right? So in this case, what is going to be the answer, my dear friends? It's going to be simple. It's if doxycycline was given in the options, it would have been doxycycline. Here, minocycline is given, so minocycline is the answer. Why? Simply because it's 45 minutes and we are dealing with an open apex tooth. If it would have been a closed apex tooth, I would never expect revascularization. So we're not going to go into this jhamela of, dipping it in doxycycline or coating it with minocycline and hoping for revascularization. No, we're not going to do that for a mature tooth. Next, friends, the next important, so that was regarding all the potential MCQs that could come for avulsion cases. Next, very interesting, and actually a very simple question came in the examination in your May INI. It was regarding the rubber dam, and they asked, they showed a clinical picture, something like this picture. This one. That's from one of my, demonstrations under the dental operating microscope, which I have in my practice. But anyways, the picture was very similar. There was a rubber dam assembly. The root canal was being done, or the procedure was being done under the rubber dam, and the options were that the clamp was of which type. It was a winged clamp, wingless clamp, with a bow or without a bow. Now for that, for those of us who've read the rubber dam chapter, it's very easy. For those of us who've not, we won't know the components or the labeling of a rubber dam clamp. Simple. You have these two jaws. One is facing the buccal, that would be the buccal jaw, the other the lingual or the palatal jaw, right? It has got 4 prongs for 4-point contact, right? So each jaw will have 2 prongs. So 1, 2, 3, 4, right? In order to hold and predictably hold this clamp while taking it inside and outside the oral cavity, you're going to engage it with the clamp forceps. For that, you have got 2 holes, one on the buccal jaw and one on the lingual jaw. Now, these 2 jaws are connected with a metallic, semicircular ring, and that is known as a bow. So here, the options were given. You had a clamp without a bow. You had a clamp with a bow. And in that also, the examiner might ask you whether it was a wingless clamp or a winged clamp and so on. So for that, it's very simple, my dear friends. If you have a clamp without anterior and lateral projections, for instance, here, the clamp, this is the clamp, right? So this has got lateral projection also and an anterior projection. These are known as wings, right? So if in the diagram you have wings, then it would be a winged clamp with a bow. Bow is always there in all the clamps. How can you have a clamp without a bow, right? If you don't have these projections, right, these lateral and anterior projections, it would become a wingless clamp, and this is a wingless clamp. So this is a wingless clamp with a bow. So just see the diagram, right, and then classify and then match the answer and mark it. Simple. It was a pretty simple question for those of us who know it, right? Just a couple of very important points I'll tell you, which nobody's going to tell you. Applied part taken directly from stud event. In order to ensure that your clamp, when placed on the tooth, is not accidentally swallowed or aspirated by the patient, you have to secure it with a floss. So you can secure it in either of these four ways. So the diagram taken from stud event. You can only engage the bow. You can engage only one of the jaws. You can engage both the jaws and the bow. So these two are recommended. That's number one MCQ. What is the recommended way of securing the clamps with a dental floss? Engage the bow and both the jaws. That's one. Second important thing, what is the length of this dental floss which is used to engage your rubber dam clamps? It is around 12 inches, which is equal to around 30.5 centimeters, right? That's about 12 inches, which is equal to about 30.5 centimeters, right? Because 1 inch is about 25 millimeters or 2.5 centimeters. So that becomes an important value-based question. This value I've taken directly from your stud event. Great. Let's move on. Let's see some other interesting questions. Yes. Which generation of file is shown in the image below? Often repeated question in names earlier and now INI. I don't know what special place in their heart the examiner has for this particular diagram. The first and important thing is to identify the file. The file is your ProTaper Next file. All right. It has got a rectangular cross section, and you can see it is off center. The center is somewhere here, right? Right. You can see that cross. That's your center, and you can see it's not in the center of the metallic portion. So it's like an off-centered, asymmetric kind of a file. That's number one. So first of all, you get an image-based question. Before answering the generations, you have to classify. You have to identify the file first. So it's a ProTaper Next file, right? Then let's talk about the generations, my friends. The generations are first generation NiTi, nickel titanium rotary files are what? They are the ones which have got passive cutting, meaning they have got negative rake angle, and the example is profile. Second generation, active cutting because of positive rake angle, and the example is ProTaper. Third generation, files which have been manufactured by special thermal processing, right, to make them more resistant to fracture and cyclic fatigue. The examples would be, so first let's write down special thermal processing. And the examples would be, my dear friends, like HiFlex CM, HiFlex Controlled Memory, and ProTaper Gold. Fourth generation is the files which have got reciprocating motion, which don't just rotate clockwise, which rotate some, by some degrees in a clockwise motion, and then by some degrees in a anti-clockwise motion. So they have to be used in a reciprocating handpiece, right? So the example would be wave 1. I'm just telling you one or two examples so that you can memorize them, and they are the most often asked MCQs. And the fifth generation is our special favorite file here of the examiner. That's your file which has got a off-center asymmetric snake-like wavy motion. And the example is ProTaper Next. All right. So the answer here is simple, fifth generation. The generation of file shown in the image is fifth generation, right? Then very important question, totally memory based, stratification based. Which of the following is not a processing wax? Straight from your Phillips, processing waxes. The mnemonic is bus. We travel in a bus, in our school bus, right? What are the various waxes that come under bus. Processing waxes, bus. B stands for boxing wax, U for utility wax, and S for sticky wax. So the answer of elimination here is boxing, utility, sticky. These are all processing waxes, and the answer is casting wax. Just for the applied part, the examiner can just go to the next level. And in your Phillips, there are certain few more examples of pattern waxes. Pattern waxes are again 3. Please memorize them. Inlay wax, casting wax, base plate wax. The next, I won't be surprised, the next year or this November, the examiner would ask you another question on these lines. All of the following are pattern waxes except. So please memorize inlay wax, casting wax, base plate wax. Inlay wax, casting wax, base plate wax. Right, friends? So this is how you should study, just the way I've taught you, right? Look at the previous year questions, identify the concept, trace the source from which textbook they've asked, from which article, and just do the related concepts, right? Apart from that, obviously, you have to do whatever you're doing, right, correctly. You have to, there are no shortcuts here. This is just a methodology which will help you in getting a better rank. All right, friends. I hope you liked the session, and I wish you all the very best for your examination. Thank you.